Good evening, one and all, to this one of the very important topic, a topic which really very fascinating and important to all the viewers worldwide, especially about the technique of digital reconstruction. This is one of the endeavor organized by the Journal of Hand Microsurgery as a virtual education series. It's continuing every week with one webinar every week, and then it goes off. For this special occasion, we have Dr. Rajendra Nethe, who is one of our pioneer and finest microsurgeon I know in India, and I also associated closely with him many counterparts. Today we will be having speakers from China under the team of Prof Wang. There is some technical issue happening around, and probably he will join us in any moment. Thanks for joining Dr. Linfeng and Dr. Hao. Right now, we'll start with the program with Dr. Linfeng, who is a specialist in hand and foot surgery, and his more work is about replantations and microsurgical free flaps. He's done more than 200 free flaps and many reimplantations. With this brief note, I request Dr. Linfeng to share his presentation and start his talk. Dr. Shenqiang.
Okay.
Yeah, please go ahead, Dr. Linfeng. Put it.
Hello, everyone. Good evening. It's my honor to have the chance to share my case about multiple finger reconstruction. There are two operation plans for reconstruct multiple fingers defect. One is finger reconstruction one by one. Every operation we reconstruct one finger. Like this photo, we use wraparound flap of the big toe and the ilium bone and the pelvic joint of the toe to reconstruct the whole finger. But we have only two big toe, so the other two we use wraparound flap of the two, the second, three, the second, third, and the fourth toe, and the medial plant flap instead the big toes wraparound flap. In this case, we can show the process. This three finger reconstruction. First, we use wraparound flap reconstruct the thumb. This is design the flap. Immediately post-operating appearance, and we use the flap from some repel the dollar side. Then we use wraparound flap from the big toe combined with ready plant, middle plant flap, reconstruct index finger. These two flap. Immediately post-operating appearance, we can see this middle plant flap, this wraparound flap. We use skip flap repel the dollar side. Next, we use Osteoonychocutaneous flap from the second toe and medial plant flap reconstruct the middle finger. These two flaps. We can see this. This is the second toe layer flap. This is middle flap, middle plant flap. On the dorsal side, we use this flap cover the second toe. The middle plant, we need skin graft. 1 year post-operating, we can see 3 reconstruct finger, 2 finger and the thumb, the appearance and the function. The dorsal side, we can see we didn't lose 1 toe. And the work function is good. The other plant, the other plants is the first stage, we reconstruct 4 finger and then separate finger. Next, we transplant layers and joints. First stage, we use medial plant flap and dorsalis pedis flap compared with ilium bone. Reconstruct the 4 fingers, bone and skin. Next, we separate 4 fingers. And then we transplant the joints to the fingers and the layer to the fingers. Through this case, we can know about this process. This case is 4 fingers defect. The first operation, we use ilium bone flap and the midi plant flap. Reconstruct the fingers, bone, and hollow skin. This is a bone. This is a medial plant flap. This is the post-operation appearance. The second operation, we used external fixation frame to separate the ilium bone. And then we do division of finger division operation. Next operation, separate fingers again. We need skin graft. The fifth operation, we replace the dorsal skin and the transplant layer. This is X-ray. The bone is good. This is the CT examination. We design the big toe and second toe layer flap. These 2 flap we have got immediately post-operation appearance. After 4 months, we can see the 4 fingers. we have got 4 fingers, but the daughter side, the damage is not is very small. The work function was not affected. But this case, I haven't complete. This case is Professor Wang's case. This method proposed by Professor Wang. This is 4 fingers defect. So this method it gets reconstruct 4 fingers, and these fingers looks beautiful. Micro fingers reconstruction is a difficult and challenging work. Many patients want to do this operation in China. I hope friends study this operation together. Thanks. That's all. Thank you.
Thank you, Dr. Linfeng, for your fascinating and really mind-blowing surgical technique and outcome. Dr. Nete, would you like to comment on this so that I can make the other speaker to share his screen?
Okay. Dr. Liu, it was a fantastic illustration, and these are really, really difficult cases. At least what your last slide said, that dream big. At least for me, even at this age, I have not dreamed so big. It is phenomenal hard work. I know that, and congratulations for achieving such excellent results. And we will have some questions at the end with other panelists. Thank you very much. Thanks a lot.
Thank you, Dr. Nath. I'm making Dr. Hao to present. He can share his screen and start presenting. Yeah. Dr. Hao.
Okay.
Just a minute, Dr. Hao. I mean, he is the associate professor and works with Professor Wang. His interest is mainly towards microsurgical replantations, especially hand reconstructions, free flaps, and he has been in various posts in Chinese medical associations, especially in the youth wing. He's very active and a close associate of Professor Wang. Professor Wang says that he has 100% success in all his replantation, and that is the credit of his commitment and dedication towards the microsurgery. I invite Dr. Hao to talk on the bone lengthening technique. Please go ahead, Dr. Hao.
Thank you, Jose. Hello, everyone. Good evening. I report the bone lengthening technique for digital reconstruction. Methods. There are 24 defective thumbs and figures, or less than 1 stage, and reconstructed with wraparound flap in the 2nd stage. And phalange lengthening is suitable for the defect with the length of phalanx stem longer than 1 centimeter. And this is a method of phalangeal lengthening. The ring finger and the little finger defect from the defect to the PIP joint. And in the first stage, we lengthen the phalanx, and first we fix 4 nails for in every figure, and then we fix the external fixator, then cut off the phalanx, and then suture the scale. This is the first case is a 23-year-old male, and he left some defect. This appearance before pre-operation. And if we reconstruct the sum with the wraparound flap directly, we need graft ilium about 1.7 centimeter. So we lengthen the sum in first stage. This is a extreme pre-operation of the sum, and this is a design of the first stage in operation, and this is the method of the first stage operation. 1 week post-operation, we began to lengthen the sum half millimeter per day, and about 52 days later, the length of the thumb is okay, and 11 weeks after weeks post operation, we remove the external fixator, and we harvest a free wrap around the flap from the great toy. This is a flap from the great toy, and we transfer to the thumb, fix the phalanx, and then we anastomose the artery, the vein, the nerve, and then suture the skin. This is the appearance during the operation. At the same time, we harvest SAIP flap to repair the donor side of the great toy. This is appearance of the great toy. 1 year post-operation, this is the appearance of the thumb and the X-ray. Case 2 is a 33-year-old male. His left index finger defect from the middle phalanx. This is the appearance pre-operation of the index finger. In one stage, we lengthen the middle phalanx, and in second stage, we harvest a free wrap around the flap from the great toy to reconstruct the index finger. This is a phalanx be lengthened. And this is appearance of the great toy after harvest the free flap. And after anastomose the artery and the vein and the nerve suture the skin, this is the appearance of the index finger during the operation. 3 years post-operation, we can see the index finger and the great toy. We compare the nail of the great toy with before, and the nail was significantly widened after operation, about 80%. These are another cases lengthening and reconstruction. This method has some advantage and disadvantage. The complication was significantly reduced, and the difficulty and the risk of the operation was reduced also, and we don't need to graft the ilium. The size of the wraparound flap reduced significantly, but the external fixator needs to be kept in the figure for a long time, about 1 to 1.5 months per centimeter. And if we lengthen the figure too long, the figures get a little thinner, and additional operation was ended. Thank you for your attention, and this is my our hospital. Thank you.
Thank you, Dr. Hao, for this amazing talk and the beautiful follow-up. I mean, we could not recognize this as a toenail where you could get that much good cosmetic and functional outcome. Thank you for this interesting presentation. Dear all, we have this. We have today's we call as the leader of the talk, Professor Wang, could manage to join us despite his technical issues. Professor Wang is a well-known, renowned microsurgeon across the world. I think he has his name in it in all those surgery and all those technical aspects. Professor Wang, thank you very much for joining us, and it's really a great honor and pleasure to have you here. A few words about Professor Wang. He immediately accepted our invitation to participate and to have a great team to deliver a topic about technical reconstruction, especially in the digits. Way back in 1996, I think he was the one who started the department in his province. He being the chief of the unit and the vice chairman of Chinese Microsurgery Association, and many more laurels to his credit, all because of his innovations in microsurgery and many more articles on microsurgery. Special credit goes to his 3-finger replanted, which was in minus 196 centigrade temperature. I think that's really very wonderful and fascinating aspect of microsurgical technique. He also coined the term super tiny, super novel, and super challenging. Especially his focus is currently now on instructional courses on various reconstructive microsurgery procedures. With this brief note, I would like to invite Professor Wang to say a few words and start his presentation. Please unmute yourself, Professor.
Thank you. Sorry, my computer have some problem. Sorry. Maybe I can't share my PPT. Some computer some problem. Maybe let's Dr. Chen.
Professor, there is an option called share at the bottom of your screen. Just click this share button. You can.
I can't share. Sorry.
It will ask your computer to change the settings.
Yes. Dr. Chen, let Dr. Chen the lecture first.
Okay. You can change all your computer settings, and then you can log out and come back again. Meanwhile, we'll go ahead with the other speakers' presentation. Is that okay, Professor?
哎，能看到我这儿吗？
看不到共享。
看不到共
Chao,
享。
我
there's
这
a
个看不到共享。Also, I cannot find the share
下面
button on my computer.
there's an option called mute,
共享是灰的。
stop video, and
Mm.
share at the bottom.
share
Yeah, but the share
Yeah,
is
continue.
gray. I cannot control it.
Only one can share the presentation. I have
So
made
somebody has
Professor,
not answered it.
I made
Dr.
Professor,
Hao, you have to.
sir, I made Professor Wang as a presenter now. Only one can present at the time.
Yeah.
Just inform Professor Wang if the share button asks for any setting change in the laptop, he can go ahead and do the changes. Let him log out and come back again. He can he will have the option of sharing it.
哎，王老师，您那个下方那个 share 那个地方是一个灰色的，还是说？
灰色要打开这个系统的设置，对，我一点它告诉我要打开系统的设置，但我系统设置不知道怎么设置，在哪一个系统设置？
苹果是不是苹果的偏好设置里面？
我的也是灰色的，我是 Windows。
不，现在是我们是灰色的，因为它只设置了是让王老师现在是 presenter 就是讲课的，我们都是灰色的。但是王老师那个是因为电脑，他那个电脑的问题，现在不能点。
那让你弄吧，跟他说一下，陈超。
倒是这种Professor Wang need to change the setting of his computer. Maybe we can go ahead with other speakers. Then
Dr. Chen,
when
Dr.
Professor Wang fixes
Dr.
this
Chen,
problem, he can go
Dr.
on.
Chen, 1 second. Can you ask him to see his control bar because it might be hidden? There is a option
Sir,
at the bottom. Your control bar is hidden, and that is why you might not be able to share.
I think Dr. Rajendra, they have found that control bar.
Okay.
The problem is he has to accept all the settings and come back again. He'll come back.
Yeah.
Meanwhile, can I ask Dr. Shenqiang to share his stage? Making him as a presenter now. He can share his screen.
Okay.
Okay. Good evening.
You see the share button on the bottom, and yeah, perfect, great.
Okay.
Great. Please go ahead. Perfect.
Okay. Good evening. I'll show our idea and methods of cosmetic reconstruction or distal finger defect pursuit of normality. Distal finger defects are common. Many repair methods and effects are also different. Our goal is to reconstruct completely normal fingers and restore the normal site. According to the type of tissues and their size, we classify the distal finger defect into 5 types. The first, bones and nails are normal, but skin and soft tissue defects. We designed free palm clamp or grid tool. Our design is very accurate. We should not only repair the fingertip perfectly, but also preserve the tissue of tool as much as possible. Immediate appearance of finger. Full thickness skin graft from medial side covers bone. 3 years later, I went to follow up the patient. He was decorating at home. At first, I thought it was the left index finger, but it was the right middle finger. Safe and functioning are good. A little difference between 2 feet. The second type is hook nail deformity. Nail is not missing, but bone, volar skin, and soft tissue defects. Osteoonychocutaneous flap was designed to carry the volar distal part or distal flanks or grade 2. The vein first, then artery and nerve. Prepare bore with speed burr. Pull out nail, spread out the nail bed. Carefully fix the bore to the proximal flanks. Be patient and carefully. The dorsal bore cortex is preserved. Advance the volar skin to the dorsal end. Perfect repair of the donor side can be achieved. Finally, the finger become like this. The reconstructed fingers are plump and have the same shape as normal fingers. The third case is distal nail defect with distal palmar skin and soft tissue defects. Designed an Osteoonychocutaneous free flap and the grade 2, and the reverse medial plantar flap for repairing the donor side. Appearance immediately after operation. It looks slightly fat on the radial side. In order to restore normal length and appearance, a verse isolate flap with the first plantar artery and the main vessel was harvested. Shape and side of the flap should fit the donor vein, so it basically restored a good shape. But at this time, the two nail looks shorter. 2 years later, function good. After all, the joints are well preserved. 2 hands look same. Shape and function of foot is very good. Big toe almost restored to normal as well as the 2 nail. 2 feet are almost the same. This is the defect of 2 fingers. We now strive to reconstruct 2 digital fingers at the same time. The point of these fingers only remain the basal part of digital phalanx. Accurate designing with full use of healthy skin of every original finger. Donor side is the big toe of both feet. Index finger, the opposite big toe. Middle finger, lateral big toe. SP lateral. This is the pre-operative design. Occurring during operation. Soft tissue seemed crowded. However, from our experience, this is suitable. When exposure in the donor vein, we covered it with VSD temporarily. A few weeks later, in order to obtain a good result, the 2 veins were designed with different shapes and sizes of flaps. Middle plantar reverse flap. And the flap was harvested carefully and preserved the plantar nerve. The finger looks same on both sides. Dorsal side, lateral side. Of course, function is good. Shape of feet is almost the same as pre-operation. Also said, case 5 is a defect from middle phalanx or long finger, like a ring. Also, an osteoonychocutaneous flank or grade 2 were designed, and the ilium block immediate appearance, hammer view, and on the side, a reverse petticoat, medical plantar flap, designed. Long narrow flap. Full thickness skin graft, but harvested from the middle plantar foot. 9 months later, hammer view. Function was also good. Feet look a little different, but most of the toenail defected. So to solve this problem, bilateral phalanx osteoonychocutaneous flap was designed. It is applicable for the distal segment defects of one finger. Harvest from both feet. 2 middle plantar flaps were designed. And then assemble them bone to bone, nail to nail. And the distal end of artery was also anatomized to reconstruct the distal artery arch. The result is a normal finger. Northern sides were repaired with the medial plantar flaps. Most of 2 nails were preserved. 8 years later, we had a normal finger. The feet looks much better. So our pursuit is novelty, and recent recipient site, we harvest grade 2 palm flap or reverend flap to reconstruct the distal finger, and at the donor site, local flap or reverse middle plantar flap were harvested to cover the donor site. Thank you.
Thank you, Dr. Shenqiang, for this very fascinating and mind-blowing outcomes. I think Dr. Rajendra, Doctor, don't have any words to look at the functional outcomes and the reconstructive aspect.
Thank you.
退出共享。
哎，咱们打不开了。
Sir, Dr. Rajendra, your comments?
退出共享桌面是。
I can't find the soft.
Dr. Shenqiang, I saw your fantastic results of finger distal tip reconstruction.
Okay.
I think I am looking at some magician's work. Because these are so fantastic results. I'm so happy. We will have question and answers at the end.
Thank you, Dr. Rajendra. May I invite Dr. Chao Chen, is also a very close friend of mine, where we met during the International Microsurgery Club and a lot of webinars. He has participated in many of the our journal webinars and also as a moderator and a presenter. He is one of the finest hand and foot microsurgery surgeon from the same province hospital. Dr. Chao, can you start your presenting your talk? I've made you as a presenter now. Please go ahead.
Okay.
Make it a full screen and please go ahead.
Okay, can you hear me now?
Yeah, go ahead.
Yeah.
Make it.
Thank
Make
you.
it a full screen.
Thank you. Thank you. Yeah.
Thank you.
Thank you, Dr. Jerome, for your invitation. It's my great honor to be here again for this great webinar. And I also learned a lot from the other speakers every time. And today, I will talk about the reconstruction for proximal finger defect. Okay. First, I know this is a controversial topic because in many textbooks, proximal finger amputation is a contraindication for even for replantation. So in my talk, I will talk about why we did it in China and how we did it and what is the best outcome we can expect. First, what is proximal reconstruction? It's obvious that the left finger defect is distal amputation, the right is proximal amputation, but what is the boundary between distal and proximal? It is widely accepted that the boundary is the insertion of the FDS tendon. Also be described by Professor Fuchan Wei. But when we look into the anatomy of the flexor tendon, we will find that the insertion of FDS tendon is not at the base of the middle phalanx. It's in the middle side of the middle phalanx. And also the insertion is not a line, it's an area. So it's very difficult to make a clear boundary. And in the other aspects, even though we lost the insertion of FDS tendon, the FDS tendon or even the FDP tendon can adhere to the remnant of middle phalanx, and the PIP joint can actively move. So now I think the integrity of the PIP joint is the key point. Even if we have a whole PIP joint, we can consider this as a distal amputation. But if the PIP joint is damaged or lost, it is a proximal amputation. And why did the proximal finger amputation is considered as a contraindication? There are two aspects. First is functional. It said that a reconstructed finger is unable to flex as the PIP joint is considered more of a liability than an asset to the patient. And another aspect is cosmetic, because the traditional toe-to-hand transplantation, a toe to replace a finger, will typically result in a shorter finger and consequently a more unnatural looking hand. So I think it's reasonable that it should be a contraindication for when we use a total hand transplantation. So, and in Green's anatomy, even for amputation, even for replantation, this is a contraindication. But I think there is a great cultural difference between China and the Western countries. In Western countries, the prosthesis will not bring with high mental stress, and now in US, most advanced myoelectro prosthesis has very fine function, but in China, the integrative body is considered very important. So the patient will have very high mental stress in China if he or she lost a finger. So like this is a 31-year-old female patient. She had the index finger defect ever since 4 years old. But why she want to reconstruct her index finger? Because he felt he was abnormal. Her daughter always asked her, "Mom, why did you lose a finger?" And he suffered heavy mental stress for 25 years. So even though I talked a lot with her before operation, I explained, even I reconstruct an index finger for you, you will not improve your hand function, and you will underwent long time operation and a long period of post-operative rehabilitation. But she always insisted on the finger reconstruction. And now, other from the outcome, the difficulty of the finger reconstruction is also the problem for such operations. What are the difficulties? First, for skeleton, the length of toe is too short, and the position of PIP joint is not in the normal level. This is the same patient. The second toe, the length of second toe is 38 millimeter, but the index finger is 72 millimeter. And second, the tendon, flex tendon. If you reconstruct a proximal finger amputation, you need to reconstruct the PIP joint, and that brings with the tendon problem. The flex tendon, you will confront with adhesion and secondary tendinitis. And the extensor tendon, if the amputation side is very close to the MP joint, the intrinsic tendon, the intrinsic muscle will lose the function. You need to reconstruct the intrinsic muscle tendon. It is also difficult. And for skin, the length of plantar skin of greater toe is much shorter than a finger. So when we design the wraparound flap, we don't want to cross this crease, but for a proximal finger reconstruction, we must cross this line. So it will bring with difficulty on the design of the wraparound flap. And what about the surgical technique? This technique has been introduced in a paper published on clinics in plastic surgery by Professor Wang. We use a wraparound flap to reconstruct the skin and nail for the finger, as well as part of the distal phalanx. And we use a vascularized Zengtao PIP joint to reconstruct the PIP joint of the finger. And we transfer iliac bone graft to reconstruct the phalangeal defect. And this schematic shows how we assemble a new finger. I will introduce the assemble in a video. And for donor side recovering, we mostly transfer a free skip flap to reconstruct the the great toe and input part of iliac bone graft to reconstruct the bone defect in the second toe after PIP joint harvested. So I will show the technique through a video. This patient is just the patient I introduced before. How we design the wraparound flap, the dorsal view, the plantar view, and the design a skate flap for donor side reconstruction. Also, we have the PIP joint from the second toe. First, we incise the dorsal side to dissect the first dorsal metatarsal artery and its two branches. One branch go to the second toe, one branch go to the great toe. So we will use the first dorsal metatarsal artery as the pedicle and to serve the chimeric flap, including the PIP joint of second toe and wraparound from the great toe. And when we dissected out the FDMA and the branch to the proper distal artery to the second toe, we harvest the joint first. And this is this skin paddle is the monitoring flap for the joint. Other from design the flap just on the joint, we change it. We change the flap to the distal part. The reason for that is we will put in iliac bone graft into the second toe, and if we put the monitoring flap here, and after we input the iliac bone graft, the skin will be too tight to close, and maybe it will result in the bone graft exposure. So, but if we put the monitoring flap on the toe palp, the joint position after we input the iliac bone graft, the skin will be loosened. It will not be too tight to close. The donor side morbidity will significantly decrease. And then we dissect the extensor tendon. And sometimes we will keep a strip of extensor tendon on the second toe to keep some movement of the DIP joint of second toe, but I don't think it is important because that joint is not important for the function of the foot. Then we dissect out at the middle phalanx and do osteotomy on the middle phalanx. We use an electric saw. You must take care of the digital artery, the other side digital artery, because if you accidentally injury the tibial side digital artery, the circulation of the second toe will be compromised. And we carefully dissected out the tibial digital artery and nerve and preserved it on the donor side. All the branches to the skeleton should be dissected out and ligated. And we can you hear me when I display this video?
Yeah, go ahead. Yeah, I can.
That's good. And we ligated the branches to the skeleton and divided. And then we we cut the extensor tendon on the proximal side and measure the proximal osteotomy side. Also, when you do the osteotomy, you need to take care of the pedicle because it is very easy to accidentally injure the pedicle. And then we complete the osteotomy, and then we dissect out the flexor tendon and cut the tendon. Then we harvest the wraparound flap. Also, we use electric saw to do osteotomy. This is not the same patient because I didn't shoot the procedure on harvesting the wraparound flap for this patient. This is what it looks like after we harvested the wraparound flap. We only harvested the dorsal lateral part of the iliac bone, and this is after we freed the chimeric tissue flap. We have two. This is the dorsal first dorsal metatarsal artery, and this is the skip flap for the downside reconstruction. We put a piece of iliac bone graft to the great toe and also to the second toe, and repair the FDP tendon for the second toe. And this intraoperative X-ray to check the fixation. After we close, we suture the skin. And this schematic showed how we assemble the new index finger. There are 5 segmental parts of the new index finger. From the proximal to distal, they are remnant of the proximal phalanx, iliac bone graft, PIP joint, and iliac bone graft, and the bone on the wraparound flap, and use the wraparound flap to cover the skeleton. The two important there are two important one is the total length of the new reconstructed index finger, and the other is the position of the PIP joint. These should be both equal to the contralateral index finger. And we use key wire to fix the bone and suture the flexor and the extensor tendons and arteries and nerves. We repaired 2 nerves. One is to the wraparound flap, the other is to the PIP joint. This is the appearance immediately after surgery. And after we did a proximal finger reconstruction, what about the outcome? I admit that after the reconstruction is just the first step. Then we need rehabilitation and tenolysis and some skill to improve the range of motion of the PIP joint. But for the best outcome we can achieve this outcome.
1、2、3、4，好，来动，快点，好。
And a lot I want to discuss about the advantages and the disadvantages of this technique. So the advantages are obvious. First, the cosmetic, it's improved significantly compared with the traditional toe to hand transplantation. It looks like a normal finger, so the cosmetic outcome is much better. And we put the PIP joint of the second toe in the same position as the contralateral finger, and thus it has the potential to achieve a better range, better function. But the disadvantages, first, it is with high technique demanding, and mostly tenolysis is needed because we cannot do early post-operative range of motion exercise, and thus post-operative rehabilitation is need a long period. And I don't think this technique need to be widely introduced all over the world, because the technique demanding and different cultural culture in different countries, the patient have different demand. But I think this technique should be considered for the patient who suffered heavy mental stress by loss of a finger, even an individual finger. And if the patient can afford the time, the payment, and the risk, of course, the risk for the reconstruction, I think this technique is an alternative to other methods. Okay, thank you for your attention.
Thank you, Dr. Chao. When though you said it is cultural dependent and essential for persons who need it, but having said that, the results are very amazing. And it all goes to the meticulous planning. Where should the PIP joint come? Where should the bone graft lie, and how to fix? I think it's really a great job, splendid job. Dr. Nethe?
Yeah, Dr. It is Dr. Chen. It is fantastic reconstruction, and as you said, this is one of the alternative treatment. I think this can be a main treatment, and other methods can be alternative treatment to this. It is excellent reconstruction. Obviously, there is a lot of skill required, a lot of planning required. As Dr. Joe said, you need to know exactly the anatomy. And I think Dr. Wang will focus more on the anatomical details of the finger. And as our professor, I think he has worked maximum on analyzing the microvascular anatomy of the fingers. We'll be very happy to share to her his views. Thank you very much for an excellent demonstration of a procedure.
Thank you.
Thank you. Professor Wang, can you start sharing your screen now?
OK。陈超，我这还是不能分享啊，灰色的。
啊，就是您有没有这个，就是在设置里边重新点一下，然后再退出，再重新登录了，是吧？
对，也不行。
还是灰色的吗？
灰色的，对。
设置里边有一个，就是得把那个授权点一下那个。
点了也不行，真麻烦。
就重新进来一下。
我出去重进一下。
不行，让陈超放领奖。
陈超的没有。
Professor Wang also confront with problem with sharing.
Okay, we'll
trying to fix it.
We'll take some questions, and then probably we can come to him.
Yeah,
for his talk. Dr. Nethe, like to have any questions to the panelist, or?
Yes, Dr. Hao. Yeah, Dr. Hao, you had an excellent presentation on the reconstruction of the distal fingers. You showed one case where there was a good widening of the toenail in post-operatively. Why do you think this nail got widened automatically, or did you do any procedure to widen that nail?
没有，陈到什么意思？他说，
就是那指甲术后那指甲增宽了，你有没有做特殊的手术去来增宽它？它为什么能增宽？
no special method, just to the skin don't healing too early, and
Okay.
the base of the nail bed will be widened.
I think
Rajendra, I think we have Dr. Wang again joined. Can you make him as a presenter now?
Okay.
Yeah, I can add some answer to this question, because for the fingertip reconstruction or distal reconstruction, now more and more we don't use flank transplantation to reconstruct the donor side. We just let it heal by secondary intention. And there are two advantages for this option. One, the procedure is simpler much. We don't need a second group to do another flap to reconstruct the donor sides. The other aspect is during the healing of the donor side, the skin will grow to cover the defect. Also, the nail bed will grow. So that's why the nail bed, the nail is significantly widened after long time of post-operative.
Okay. Thank you.
Thank you.
Is Professor Wang ready, or can I ask another question?
Sir, I made him a presenter. Let him try this time.
Yeah, please.
Dr. Wang, Professor Wang.
可以了，好像是，可以了。
Perfect, I think. Finally, we have got it. Yeah, great.
Yeah,
看到我吗，陈超？
可以了。
可以了哈。Okay. Good evening. Amputated finger. Replantation is more simple for reconstruction. It's a 10 finger and finger and some thing. Side replantation. But perfect replantation is now difficult. Function and appearance close to normal is difficult. For this example, this case, a thumb amputated. Replantation post-operation or 1 year, and good appearance and good function. Finger amputation as suited face tissue defect. We use the C flap from critical anatomy. C flap. This is a C-shaped flap. For this case, C flap, digital lock with like a flow-through flap, and the dot skin, like the finger dot skin, and the wall skin, like fingertip replantation. post-operation. And a tissue replantation finger. This just a tooth, severed tooth. Replantation. 1 year post-operation. Super microsurgery, the flap replantation. It's just a flap. And most is one wing and one outer branch, and the wing. This several flap. 1 year post-operation. A mini flap replantation. It's just a little mini flap, a little skin replantation. Just can find one artery, 0.1 millimeter. And 2 months post-operation, and 1.5 years post-operation. This is the mini flap replantation post 1.5 years post-operation. This mini flap. Some fingers show the immediate replantation, but sometimes we can't. For example, and 17 years ago, a patient with severed index finger. I wanted to replant a finger immediately, but the patient refused because the patient cut off his own finger. I put the finger in the liquid nitrogen and preserve time, and 81 days. The patient come back, and then he asked me to reconstruction a new index finger for him. But our colleagues told the patient his finger, severed finger, we preserve for him. So he asked me to replantation the finger. After 80 days, and the wound already healed, and the wound already healed after 81 days later. After 81 days after cryopreservation, we warming the finger and replant. 1 month post-operation and 1 month post-operation, 6 months post-operation, and the bone and the vascular. And the second case, 14 years and this is the first case, the case of 14 years post-operation. The second case. Refuse cryopreservation solution. And the program cryopreservation. I put in the liquid nitrogen. 5 days later. Replant. And the repair after with transplant with the vein. Second month preparation, and 13 years post-operation, and a good appearance and good function. And the joint and the bone, the joint function and the function.
If you lose a finger, plastic surgeons may be able to reattach it using microsurgery techniques and technology. Unfortunately, some patients either initially refuse the surgery or can't have the surgery because of organ failure or other issues. Traditionally, these patients would be just out of luck. Their amputated fingers would expire and replantation would not even be an option. Plastic surgery researchers out of China may have found a really innovative solution. It is called cryopreservation, a deep freeze widely used to preserve bloodless simple structures like semen, ovarian tissue, and embryos. But could it work in a complex structure like a human finger? Based on initial success in an animal model, these researchers tried the technique with two people's fingers. One man's finger had been cryopreserved for 5 days, and the other one for 81 days. Wow! In both cases, the surgeons attempted the complex replantation with the frozen fingers. Amazingly, both men showed favorable results in the short and long term. At 15-year follow-up visits, both men showed successful grasping and holding and even pinching actions, adequate bone healing, good range of motion, and only mild atrophy. One of the men even showed advanced fine motor ability. Research and technological advancement is needed. This new hot topic in plastic surgery means that cryopreservation could truly be used to salvage digits and even limbs for future transplantation or replantation. To learn more about these incredible medical and plastic surgery innovations, read the #1 journal in all of plastic surgery in the world at prsjournal.com.
In general, not all the amputated fingers can be successfully replanted. For this case, we can't replantation. Some finger reconstruction need. Many methods to reconstruct the finger and the thumb, but the total hand is the best method. For example, is the second tool to transfer to reconstruct the thumb. But we use the tool to reconstruct the thumb. The second tool is too thin and the group tool is too thick. So we use this method. We transfer a flap, put it here. Let the second tool become thick. This is the second tool. This is the flap. So the flap put here. The second tool looks like the thumb. This is the second tool. The second tool is the flap. So the second tool become thick, look like the thumb. But if we use the second tool or the group tool, use the tool, you can reconstruct with the finger. And the second tool is too thin and the group tool is too thick. But also the second tool and another tools is too thin, too short for the reconstructing the fingers. For this case, we transfer 4 tools to reconstruct the 4 fingers. It's a good function, good function, but the finger is too short and look like look like the toes. And the feet are very ugly because every foot lose two toes. Why transplant to the whole toe? Or can we only transplant a part of the toe and transplant the tissue from somewhere else over the body and use the different tissue from our body and make or build a new fingers of thumb? This is a new technique in thumb and finger reconstruction. And the transplantation tissue from all over the body make a new finger and thumb with usual various tissue. The key technique of the reconstruction is the design, and the key technique of design is clinical anatomy. We do many anatomy in the flesh cleaver. It's the flap and the flap and the what's called anatomical tree, anatomical levers, and the vein in the gluteal and in the wall. It's the vein and artery. Then I know almost every artery and the artery branch, and I can use can transfer a tissue from everywhere. I can use the new technique to reconstruct the finger and the thumb. Classify according to anatomy. And the artery, bone, and the nerve, and then the flexion tendon, extension tendon, and then the volume vein, and then the dorsal vein. For this case, Hockney, we use the bone flap and 2 years post-operation. There's a post-operation, but the gluteal lose most parts, large part nail. We use another method and to let the nail looks better. Use this method. Post preoperation, a little part, and combine and transfer and a large part of a nail. Post operation, problem post operation, and the nail looks better than before. Another method. This is a file effect of the grade 5 effect. Preoperation, post-operation, and the function, and still at 10 toes, just lose some skin or nail, and the foot function, and the this is the greater 6 defect of the thumb. Appropriation, greater 6 post-operation, and 3 years post-operation, and the thumb, the foot, and the thumb function. And the foot function. and multiple finger reconstruction. This is the 2-finger reconstruction: pre-operation, post-operation, pre-operation, post-operation, and then the function, and the 10 toes just lose the nail. The
十字绣可不是一件容易的事儿。
The right index finger and the right middle finger is reconstructed by us.
瞧，就在这精美交织中，他手里的一针一线上下翻飞。如果我告诉您，这么灵巧的手指其实是脚趾，您能相信吗？小梦正在配合王主任做一系列的功能测评。现在的这2根手指，无论是触觉、压
And the 3 fingers reconstruction, and the 4 fingers reconstruction, pre-operation, post-operation, and post-operation. Thanks.
Thank you, Professor Wang. We're really mesmerized. If you're just watching your slides, those really an incredible outcome in surgical planning. Thank you for joining us and presenting a very important and essential topic of digital reconstruction. But Rajendra will take over from here.
Thank you, Dr. Wang, for excellent demonstration of the different techniques for reconstruction of the fingers and thumb. I'm sure this will stimulate many of the younger surgeons to take up this to a next level for the reconstruction. I would, however, I would like to ask you some questions about this. Firstly, thinking about the culture, we have a similar culture where our patients also demand the reconstruction of the fingers, but somehow it is very, very difficult to explain them to sacrifice any part of the toes. So how did you overcome this? Because when you started, it must have been new. And how did you overcome this by explaining to the patient and getting consent for such multiple flaps for reconstruction of the fingers?
是那个就是很多病人就很难，就是说服他们去做。他有的病人就是包括花费啊，还有这些从脚上取很难说服他们。就是这些新技术，这么多的新技术怎么和病人说服病人来接受，然后并且来实施的。
谢谢帮我回答一下，也是就是直接就是说这个脚的话，并不脚的10个指头都在脚的损伤，跑脚都没影响。另外一个的话，是脚损伤很小的话，它就可以。第二个的话，就是现在中国人比较多，也的确是，因为我们这做的比较好嘛，全国都集中我们这个地方来说，我们的病人比较多一些。但现在这个医保经济上也国家能报销一部分，这3个因素是病人我们排队好多年，病人等的非常多。你说一下3个因素。
Okay, I can answer translate the answer for Professor Wang. Yes, it's true. I remember when we have a webinar in IMC and the Professor Gregory Bunke asked the same question to Fucheng Wei. He said I found it difficult to let the patient to accept the total hand transfer. But in my department, first we are a center for digital reconstruction in China, and it's very famous. So there are many patients want to do this surgery. Maybe it's just a small part of all the people that have digital loss, but all the patients come to our department, they all want to do the reconstruction, and we will show them the cases we had. The cases we have completed the operation, we will show what will the foot become after the surgery, what will the finger become, and most patient will accept. And the most of the payments will be covered by the insurance. Some are by some companies, other by the national insurance system. So the payment is not very quite high in China for finger reconstruction. So, thank you.
Okay, thank you. I wanted to ask Dr. Hao about the bone lengthening. He said it. He regularly does 1/2 millimeter a day. And how it is? How do you get any complications in this little pin track infections or deviation of the finger to the or angulation deformity of the fingers or non-union of this bone? Because if you are keeping it for 1 centimeter, it is around 1.5 months. So do you land up with such problems or?
那
他是说怎么术后怎么判断这个长多少？
就是那个你在骨延长的时候，它会就是一天你怎么这个速度一天是1毫米还是怎么着？
对
然后这骨延长的时候有没有碰到成骨不全，这个成骨畸形偏斜，就 deviation 这个偏斜，就是或者
对
就这些并发症是说一下。第二就是怎么来避免这些并发症。就第一这个速率，第二这个并发症，第三怎么就是避免这些并发症。
Yeah, okay. After operation, we need we land the patient to do the X-ray examination about 2 or 3 weeks. Every the figure length it lasts about 5 millimeter. I need X-ray examination every 5 millimeter about. And if we see from X-ray, the new bone is not good. We should slow the speed. For example, at the beginning, we at the first days we length half millimeter per day, but maybe 2 weeks later we found we see from the X-ray the bone is not good. We just length about 1 millimeter. We need the 4 or 5 days, not 1 day. Sometimes we should stop for some day, stop for 1 week. But some patients, especially the children, we need faster, about 1 millimeter per day. So we hold the patient several times, let them come back several times every 2 or 3 weeks. It's important, very important.
Prof Wang, I wanted to ask you, when you plan for multiple finger reconstructions in one go, how do you plan your anastomosis? Which arteries you take?
这什么意思？就是以再造目的
the
是
please pardon, please repeat
Can I
your
repeat?
yeah.
Can I repeat question?
yeah.
Yeah, when you do multiple finger reconstructions,
Yeah.
which arteries you take as recipient vessels? Because I saw sometimes you have done 4 finger reconstruction in one go. How do you plan your anastomosis?
For Dr. Hao,
The plan of vascular anastomosis.
yeah. The question is for Dr. Hao or for
就是
who?
二期
就是你在这个重建的时候怎么来匹配这个血管，
血管
匹配的血管，选择什么样的受区的血管？哎，他这个问题是问谁的呀？
意思就是延长了以后血管可能会变细，是不是？
Hello, is this question for Dr. Hao or for other panelists?
Professor Wang.
Professor Wang, OK。
嗯，
就是您在那个在做这个再造的时候，就是怎么来匹配这个受区的血管，就怎么来选择受区的血管，怎么来匹配，就是不会出现这个就是血管吻合的问题，怎么选择受区的？那个没有开静音，您现在静音。
哦，就是你说一下，就术前那个用 B 超做看血管，一般能指动脉就用指动脉，我们一般都是远端有血管的，只要指动脉有的话用指动脉，就是都是选择那种最远端的那个血管。你说就是。
OK, yeah.
但这对小的很小。
I will answer this question. Is also it's an interesting and great question for finger reconstruction because we different doctors have different chosen for the recipient vessels. For in my department, we most patients we will use the proper distal artery for as the recipient artery and use the superficial dorsal veins for the recipient vein. We don't use the radial artery or very proximal artery, and the success rate is very high. There's no problem because it's just like replantation. And when the donor site there are different anatomical variants in the first dorsal metatarsal artery. In some cases, FDMA is absent or is very difficult to defect. For me, I only just harvest it at the most proximal site that I can dissect it. And then I will use a wing graft. Wing graft is a very reliable option to solve the pedicle problem if it is too short. I don't think venous graft is has more risk or higher failure rate compared with other solutions like you harvest arterial graft or other solutions. Okay.
Okay. Thank you. So that's it, Terrence. There are no questions in the chat box. Do you have any questions to ask them?
I think most of the questions have been answered and dealt with you and Dr. Chao Chen. We will have a quick 30-second closing remarks from all the speakers, and then finally we can end the session. We'll start with Dr. Chao Chen. You can inform your speakers about quick 30-second remarks, and then probably we can have a final word.
A closing remark?
Yep.
Yeah. Yes. Okay. Yeah. I am glad tonight for this webinar you arranged. It's an opportunity for our team to share our cases, our techniques worldwide. And it's also we learned a lot during the discussion with with you and with by answering the questions. I'm glad and I am looking forward to learn from other speakers during this webinar. Thank you.
Thank you. Professor Wang.
Hi.
Yeah, would you like to say something, sir?
就结束语说几句话。
我这名字经常不会读他的名字，待会儿
Jerome，你写这些就是写这个 doc 才行，无所谓。
不知道怎么读这个英文哈。你读一下 Terrence 到人的。
Just Jerome，Terrence just Jerome。
还Dr.
Prof Wang said he don't know how to pronounce your name.
Sorry. Good evening. Dr. and parents Jerome, and Dr. General Thank you for give our this 机会听到这个
opportunity
and我经常不会说
Yeah, I think the closing remarks, because in the most doctor in my department don't communicate with the foreign doctors a lot, so the speaking English are not very good. I think the all feel it's a very good opportunity for us, and they want to show their thanks, show their willing to learn from this webinar in the future. I think I can give the closing remarks instead of them.
Yeah. Thank you.
In fact, Terrence, I will say something.
Yeah, please.
Yeah. So, Professor Wang and all the speakers, it has been an excellent webinar and very stimulating and inspiring webinar to stimulate us for the finger and thumb reconstruction. You have given us very new insights into and the details about the reconstruction techniques you use. And I'm sure the younger generation has a lot of things to learn from you. And we would definitely like to have you people as faculty in one of the Indian conferences to speak on these finger and thumb reconstructions, and we'll be very eager to welcome you out here in India. Your remarks, Terrence?
Thank you, Professor Wang and his team, Dr. Chao Chen, Hao, Dr. Linfeng, Dr. Shenqiang, and the moderator, the special moderator for this event, Dr. Rajendra Nethe, a very close friend of mine. Indeed, as I was mentioning, we learned a lot. It's really an eye-opener for the generations of, like our generations. Dr. Rajendra has done extremely well in replanting all 10 fingers, and then he has passed his baton to the younger generations. These are the motivating webinars of how to reconstruct fingers, complicated finger defects, meticulous planning and execution of microsurgery technique. I think this is the one message which we all been trying to pass it to the generations to come, especially in the field of reconstructive microsurgery. Thank you all for being patient with us, though we had a little technical issues in the start, and then we could have all the talks together this evening. Thank you, and stay safe. Wish you all safe and healthy. Looking forward to see you again in another webinar. Thank you all. Bye-bye.
Thank you.